Dr. Alicja Fishell is our next speaker. She is a staff psychiatrist and education coordinator of the Reproductive Life Stages program in the Department of Psychiatry at Women's College Hospital and a staff psychiatrist at Sunnybrook. Her clinical interests include women's reproductive health and development of clinical services for integration and continuity of care for women experiencing mental illness in the transition from pregnancy to postpartum period. She's especially knowledgeable about depression in pregnancy, our next topic, and I'd like to thank her for taking the time to speak to us this afternoon.
Hello, thank you very much I'm very pleased to be here today and for inviting me. And I do have a disclosure too. I do not work with pharmaceutical companies, except I do use a lot of their products. Not myself, I mean, I prescribe them for patients. And I do have to say that I have made the best decision in my life by becoming a reproductive psychiatrist. It is a true pleasure to work with women who have difficulties with mental health during pregnancy and postpartum period and with their families, and to see the outcomes of the help that they can get. So the title, in a way, is a little bit misleading, and I apologize for that, because I will talk also, I would like to review impact of untreated maternal depression on the fetus and neonate and the child down the road and the mother. However, this talk is going to be interspersed between depression and anxiety, because we are seeing right now, actually, over the last few years, clinically in our offices, as well research-wise, it's coming up that actually anxiety disorders can cause more problems to fetal development if they are untreated and fetal and child development down the road than actually untreated depression. So it's important to kind of focus on both, since they are treated with the same medications. Look at some effects of fetal exposure to psychotropic medications, time constraints. I wish I was giving a lecture. I can only talk about antidepressants and very little, okay? And answer any questions later and summarize the general kind of management with respect to treatment of perinatal mood and anxiety disorders. As you probably know, the prevalence of depression in women is twice that in men, and at least 25% of women will develop depression during their lifetime, and the highest risk of developing the depression during their lifetime is during their reproductive years. As mentioned already before, think about then in terms of considering that about 50% of pregnancies are unplanned. A lot of these women may already be treated, which means they get pregnant while they're on medication, antidepressants or other medications, or they may not be treated, may be well, and they can relapse during pregnancy, or they be unwell, they get pregnant and continue to be unwell during pregnancy. I was going to have a slide on myths about pregnancy and depression. However, I just put one point here. The myth is that pregnancy protects against mental illness, and especially depression. It does not, actually. Up to 70% of women will say that they do feel some depressive symptoms during pregnancy, and about 12 to 13% eventually develop major, what we call depressive episode, where they fulfill full criteria for depression. Why do we want to treat women with significant, severe, moderate symptoms during pregnancy? Because the outcomes and impact of the symptoms of depression and anxiety on the fetal development and on obstetrical outcomes and in development of the child down the road is significant. And we know more about that than we actually know about treatment and safety of medications. So with respect to fetal and obstetrical outcomes of untreated depression and anxiety during pregnancy, we know that it increases those symptoms, maternal symptoms, increase risks for spontaneous early labor and precipitous labor, increase preterm risk for preterm delivery. The infants have risk for lower birth weight. There can be fetal distress. There's increased risk for actually decreased fetal growth and increased risk for miscarriages in first trimester. And it has been correlated maternal symptoms, especially of anxiety and severe stress, to increased risk for preeclampsia. That's been nicely correlated with what we call trait and anxiety in women during seventh month of pregnancy. And there is an increased risk for operative deliveries, not necessarily C-section, that the vote is split on that, but instrumental deliveries like forceps, for example. Risks to newborns of maternal untreated depression, anxiety. Their children are more likely to be admitted for distress to an ICU. They have lower APGAR scores and smaller head circumference, but there's evidence for that. They may show some growth retardation and slow mental development, as well as the newborns, and up to several months after delivery, the children show excessive crying, irritability, hostility, and erratic sleep. So if you can imagine having a woman who is unwell, depressed, or very anxious, when you have a child that doesn't sleep during the night or is on the breast constantly when they are breastfeeding, and the woman can't sleep and can't protect their sleep, that just makes the mother feel worse, and that further compounds the problem. So what do we know about untreated depression and anxiety during pregnancy and impact on child development down the road? There's definite correlation between negative effect of maternal-fetal bonding and maternal-infant bonding. Children are having difficulty with what we call affect regulation. And what is that? That's basically tantrums from hell. And in small kids, in toddlers, these children have very hard time containing themselves. And I've been assaulted or doing psychiatry and working at a very high-risk wards, at Queen Street in Toronto years and years ago. I've been assaulted only once by a patient, which was 20-month-old boy in my office who ended up hitting me, came from behind me. He was really frustrated and having horrible tantrum, came and hit me right across the face from the back like this. And I've never been assaulted ever by a patient before. So that tells you something. There's an increase for cognitive delays in these children, especially speech delays and behavioral emotional difficulties, and maladaptive social interactions, as well as delays in those milestones when those social interactions can start happening around age 4, when the kids start hanging together. These children can display more fear and anxiety and have more insecure, what we call, or disorganized attachment style. And what it is we want every person to have secure attachment style. Every child and secure attachment style, and that translates into having secure attachment style as an adulthood. That protects us from decreases risk for getting any kind of mental illness. It increases positive interactions with people. People have more friends and more support. Therefore, even if they get unwell, there are people there that are supportive and they can help them and they come out of it much quicker. Furthermore, there's a higher rate in these children for attention deficit hyperactivity disorder, and longer follow-up shows more impulsivity and lower IQ in teenage years. We know all about the risk to the mother of untreated maternal depression and anxiety, poor nutrition, impaired self-care, failure to follow medical and obstetrical perinatal guidelines, worsening of comorbid medical illness. People don't think about it, but if you don't feel well, especially stuff like diabetes, for example, or not being compliant with taking medications, for thyroid medications, increase to tobacco. However, remember also this, that the highest risk factor, the biggest risk factor for developing postpartum mood disorder or postpartum anxiety is having the symptoms during pregnancy. So that's the highest risk factor and predictor for having postpartum anxiety or depression. And the most common symptom of depression during pregnancy or anxiety is irritability, so family members and other children and family suffer. What do I want to talk about antidepressants? So, well, you all know about SSRIs and SNRIs. I have listed them. I will just tell you from my own experience which medications I use the most. For SSRIs, I use the most sertraline, fluoxetine, fluvoxamine. Luvox is not really used very much at all, not even in this patient population, and citalopram. I also use frequently Effexor venlafaxine, which is a serotonin and norepinephrine reuptake inhibitor. Do I use Paxil? Yes, I do use Paxil. There are women out there who have not responded to other medications except to Paxil, and they do very well on Paxil. I will not risk changing them to other medications or try something new or something different because I know this works. So even though there's all the controversies around major malformations, cardiovascular malformations possibly caused by Paxil, in all these controversies in different studies back and forth, Paxil, it is feasible, good medication for some women, and for some women it's the only medication. I segregated the Cymbalta and escitalopram and lower because those are new medications. We know very little about them. There haven't been any studies with respect to pregnancy outcomes. Many women, because they are new, they are fashionable, many women do come on these medications to my office. If they are on them, I am not going to change them when they are pregnant to something else, because if it's working, why mess with it, right? And then I don't know whether the next medication that I offer, whether it's Zoloft or Prozac, is going to work for them. So I leave them on that medication. However, it's not the drug of choice when it comes to prescribing during pregnancy, those lower down. Still use sometimes tricyclic antidepressants, typically stick to nortriptyline or disopramine because of the least anticholinergic side effects. This is important, especially if women have first trimester bleeding. So I have initiated some women on nortriptyline, for example, or disopramine during the first trimester because I don't want to increase the risk that comes for bleeding from exposure to SSRIs or SNRI. And some women respond very well to Wellbutrin, which increases dopamine and norepinephrine or Remeron. I will not talk about the other psychotropics, the new antipsychotic medications or mood stabilizer. I will mention that do use quite a bit of lorazepam for sleep as needed during pregnancy, and occasionally clonazepam when the symptoms of anxiety are so high that the woman can't function properly until the SSRI or SNRI starts working. However, will every woman take medication who has severe symptoms? No. And the big reason why is, there's been studies published on this, but this is also partially kind of my clinical experience. Stigma. They will take stuff for acid reflux, omeprazole or something else, but they will not take SSRIs for severe anxiety and severe depression because it's a psychotropic medication. And clearly this group of women will say, I will not take anything that will harm my baby. So immediately that harm, the idea of harm is there. They said they can beat it off with a stick or with a bat. They will try anything else first before they try the medication. So the big thing is fear of medication harming the fetus. Interestingly enough, most women I'm seeing recently are not taking the medication when they should be taking it because they are afraid of baby developing poor neonatal adaptation syndrome. And we'll talk a little bit more about that, which is the effects of exposure to antidepressant in a newborn baby. They're afraid of the unknown effects on the child development down the child. And of course, we all talk about web and access to web. They get on the web, they see all this unbelievable information, which makes them more anxious. They bring it back to the office and they get even worse symptoms. And it's very difficult to discuss this issue with somebody who is so anxious and afraid already. try to reassure them, well, I read it at so many sites. Well, okay. If the partner is not supportive, that can be a problem too. Some men will say, or partners will say, that they don't want their partners to be on medications. I actually had one father say to his wife in my office, "You're not going to make my child into a zombie." But we do have this other group of women who actually say, "I am so sick that I'm afraid that this is harming my baby," and they're right. These are women typically, there are smaller numbers of these women, and they will say that, and they'll say typically they've experienced it before during pregnancy or postpartum period, whether it's depression or anxiety. They have very good insight into their illnesses, and they will take the medication or remain on the medications during pregnancy or come for pre-pregnancy consultation and start treatment or change medication to another medication, depending on what they are on. So that's a good news. We all talk about this, and I will be talking about this, what we know about the antidepressants used in pregnancy with respect to the malformations, SAs, preterm birth, and neonatal outcomes, which is specific. The PNAS is very specific to the antidepressants. We were all very comfortable prior to 2005. I mean, we were all talking about it. We all likely know about this, that all the studies showed no increased risk in major malformation with respect to SSRIs, including paroxetine and Effexor and Wellbutrin above the baseline of 3% or 1% cardiac defects. Since 2005, there's been a lot of controversies about the increased risk of major malformations, especially cardiovascular malformations. And depending what, all I want to really say about this, what's really important is it's very, very important, and there is a good paper from Mother Risk to review this, to be very careful how you read the studies, because the study designs can lead to faulty conclusions with respect to whether minor or malformations are included in the data or not, whether there is a detection bias, whether there is a control for maternal symptoms, even when it comes to studies that look at registries of prescription filled. The fact that prescription is filled doesn't mean that the woman is taking the medication. I've had many patients either not increase their dose because they think it's going to be worse for the baby, or that tell me later that I am not seeing any response, and they tell me later, that they actually didn't take the medication. They kept filling the script out. But the consensus at present time is antidepressants do not appear to increase the risk of overall congenital malformations above the baseline of 3%. With Paxil, there may be a very small increase risk for maybe, I'm saying maybe, small increased risk, both especially for cardiovascular malformations. However, we all agree who work in the reproductive psychology field that use of antidepressants for depression or anxiety during pregnancy is acceptable. Antidepressants do cause obstetrical complications, very, very small risk of increase above baseline of spontaneous abortions. It's so small that it's almost not significant. And there's no difference between different antidepressants, whether they increase more one antidepressant above other, more risk of the spontaneous miscarriages. There is in the past we didn't think that there was a risk for preterm labor. However, more recently we think that the risk is there. It's very, very small. However, when it comes to lower APGAR scores or lower birth weight, the evidence is very small, it's inconclusive. So overall, again, when it comes to obstetrical complications and antidepressants, the antidepressants use is acceptable despite those tiny risks. And now moving on to neonatal outcomes, which is poor neonatal adaptation syndrome. What is it? It is, originally people thought that this was a withdrawal in a newborn from the medication. It is not. This is not discontinuation syndrome as we know in the adult. This cannot be a discontinuation syndrome. It's likely a combination of serotonergic toxicity, or what we call in adults, when the syndrome serotonergic toxicity is the serotonin syndrome or serotonergic toxicity, and discontinuation syndrome. There's got to be other factors that are predisposing some children to get it and others not. Genetics must play a role. Type of medication the woman must play a role. This is not only about half-lives and how quickly the medication washes out, because you see it also with Prozac, not only with Paxil. Interestingly enough, and I would invite people maybe to do a study on this with me, because I don't have time. I'm the only psychiatrist out of 7 left in the program right now. Nobody looks at the K of, as a biochemist in the past, nobody looks at the K of binding of these antidepressants to serotonin transporter or other receptors. And I think, and then nobody looks at the anticholinergic profiles. Why does Paxil causes more problems than under antidepressant? The KO binding is the highest, but also it has the broadest binding capacities to other receptors. So there's likely a slew, a combination of things that are contributing to this syndrome. It occurs up to 30% in newborns. Onset, it can be immediately after the delivery or few hours after or a few days after the delivery. And the symptoms are transient and they go away within a few hours or a few days. The longest reports are for a few weeks. The common symptoms are irritability, jitteriness, hypertonia, increased reflexes, some difficulty feeding. They are restless. These kids are restless. They need containment. No evidence at this time that there are any if the child has that, if the baby has those symptoms, that there's any long-term impact on child development. They don't require transfer to an ICU. If they have respiratory problems or if they have seizure, they absolutely have to be transferred to an ICU. Therefore, they have to be monitored very closely. So the consensus with respect to the poor neonatal adaptation syndrome is use of antidepressant is acceptable. However, psychoeducation and education of the parents is of most importance, and also care providers. So when I send, for example, a consultation note back, I describe the syndrome and then I describe what to look for. Okay? So, or I send it to labor and delivery suite standard form, and the children are being monitored in the hospital or by a midwife for these symptoms. So it's very important to do that. And usually up to 3 days monitoring is sufficient, and when the children get discharged from hospital, they should be followed by a pediatrician in a follow-up clinic very soon. One line on persistent pulmonary hypertension of newborn has been proposed to be linked to exposure to SSRIs during the second part of pregnancy by Chambers in 2006. It can be deadly. However, there's a lot of controversy around it. The study design and their results were not repeated. Therefore, we don't have enough data to link this at this point to exposure to SSRIs. Finally, developmental outcomes of children that have been exposed to SSRIs or other antidepressants. We have reassuring data, but very limited. Most of the work has been done by Irena Nolman here. And what we have is, the information that we have is that no difference has been found in children up to about 7 years of age in global IQ, language development, mood, temperament, activity, destructibility, or behavioral problems. So those are promising results. Again, the data is limited. And this is primarily done with the fluoxetine and tricyclics, right? Irena? Yeah. So we also want to look at other antidepressants. So to close up, what's the goal? The goal is keep the mother-fetus unit and mother-baby unit well. That ultimately keeps the family well, and everybody moves forward, and everything is okay. We all talk here about risk-benefit analysis, but when you think about psychotropics and the stigma around psychotropics and where they act, I kind of expanded a little bit more, because when I do risk and benefit analysis in my office, I see the patient and the partner typically for an hour and a half. And I do a thorough risk-benefit analysis, because we're talking about somebody's baby, somebody being concerned about the baby, somebody concerned about development of their fetal brain. So what it is, it's just typically it's generalized. You do history, comprehensive history, including past psychiatric history, and very importantly, any responses or any trials of psychotropic medications. You establish the severity of maternal symptoms. You consider also well-being of other family members or other children. And you need to, and why I'm saying this, because I have heard from some clinicians and researchers in the States before that they actually don't do this. They don't tell the patient about the potential risk of an untreated illness on the fetus and child development, and they don't tell them about the potential risk of exposure to medication during pregnancy and poor neonatal abstinence syndrome and development of the child. So I put this in red because it's absolutely necessary to do that. Some people are too anxious, some women are too anxious, so there has to be a moment found at which point that intervention can happen. So ideally, how do I manage, or how do we want to manage depression and anxiety during pregnancy? I want to manage it before a woman gets pregnant, okay? I am, doing all this education. The first paramount thing is if a patient has history of any mental disorder, whether it's anxiety, depression, schizophrenia, schizoaffective disorder, bipolar disorder, they should, and they're on medications, they should have pre-pregnancy consultation, because you want to have a plan in place, okay? That's very, very important. That's about care. That's really about care, having that plan in place. Unfortunately, we're not getting too many of that, although getting more than before, because we've taught so many residents in our program that now that they're staff, they're sending more patients beforehand. So we're doing perinatal consultation focus on this risk assessment and treatment tailored to that specific patient with respect to what kind of medication they may need. And it's very important to document this risk-benefit analysis. As you know, in states, if you put Paxil in and lawsuit, you're going to get millions and millions of hits. That protects the patient with respect to giving them empowerment that the information was given to them, and it also protects the physician. If symptoms are mild, clearly we're not going to go with medication. We're going to go with psychoeducation, and we're going to go with symptom management through either interpersonal therapy or cognitive behavior therapy. If medication is indicated, we need to avoid, if possible, exposing the fetus, or if they are breastfeeding later, to more than one antidepressant or agent if possible. That's why if somebody comes in on, escitalopram, I'm not going to be changing them to Zoloft. What's the point if escitalopram is working, right? Keep in mind, because of the physiologic changes of pregnancy that colleague mentioned earlier, there is a possibility for relapse during pregnancy, even if the women are on medication. Therefore, it is important to monitor for the symptoms and increase the dose as needed. Choice of medication as a first choice or for treatment is purely based on previous personal use. If somebody, again, I will repeat it, has been on Paxil before and they responded, I am going to suggest Paxil. I'm not going to suggest anything else. However, if the patient develops symptoms first time during pregnancy, typically I go because with Zoloft, something like Zoloft, or Effexor if they're extremely anxious and we need quicker results, because favorable profile later when it comes to breastfeeding with something like Zoloft. So in summary, use of antidepressant in pregnancy is acceptable. Treatment decisions are based on severity of maternal symptoms and clearly the risk-benefit analysis. I think it's imperative that there is a plan with the patient and the partner which covers all options for treatment, and it's flexible. I always say to my patients and their partners, if A happens, then we do this. If B happens, then we do this. If C happens, then we do this. D is the last option, which is medication. The first thing is sleep protection, but that's another talk. Okay? There's no such thing as non-exposure. The fetus or the newborn child will be exposed either to maternal symptoms or to medication, or if the mother is not treated properly, to both medication and symptoms. We want exposure only to one, either illness or medication. Therefore, if we're going to treat and use antidepressants during pregnancy or any other medication, we increase the dose to the point where woman reaches full remission. There's absolutely nothing going on, and she is absolutely fine. So that's it. Sorry.
I just had a
Go
question.
over time? Sorry.
Do we have time for questions? One question. Oh, good one. Okay. Pressure's on. I have a question about PNAS, the neonatal abstinence. It strikes me that the trend we see with pregnancy is that they tend to be undertreated, because even if, like you said, if you increase the dose, or the patient may still feel apprehensive about it, not take the full dose. Is a neonatal abstinence associated with depression and anxiety? And if that's the case, have you seen any well-controlled studies that have shown that moms that are euthymic, that are well-treated, still have the neonatal abstinence in exposure?
You're talking about neonatal abstinence syndrome, or you're talking poor neonatal
Poor
adaptation?
neonatal adaptations.
So the question
is, do we know that it's the drug and not untreated depression, because so many pregnant women who are on SSRIs are under medicated?
We know that it's a real entity related to the drug, exposure in the third trimester. However, interestingly enough, babies that are exposed to severe maternal symptoms show some of these behaviors also. That's why they need to be transferred to an ICU. But it has been established by now that it is the effect of the medication.
Thank you.
We've always known that if the mother's not happy, nobody's happy. And Dr. Fishell has shone light on that, and we thank her for that.